I'm going to leverage the conversation that Mike just had and set up some strategic vision around some of the things that we're doing here in Medic. I'm going to split this section up into kind of two parts. One is to talk about sort of the integration of some of these new endeavors within the value partnerships and CQI portfolio with how that touches Medic. And then use that as the next step to talk about a new quality initiative that we were just vetting through the executive committee, and we're going to pitch to all of you. So as Mike was saying, there's this doubling down on the model and the expansion of these programs into more population health and chronic disease management. And some of that certainly interacts with our work in the emergency department, and we'll talk about that here. That being said, this first one doesn't exactly fit that portfolio exactly. This is more on acute care, hospital-based care, but I think it's important that we talk through this as well. So this is an opportunity that we're discovering with another CQI, HMS, which is the Hospital-Based Care Collaborative. We have heard about them occasionally in some of our meetings. In fact, one of their medical directors, Scott Flanders, talked to us, I think a couple years ago, about some of their work around antibiotic stewardship, focusing on pneumonia and urinary tract infection treatment. They are launching a new initiative on sepsis, and there's a lot of resources being devoted to this effort. As you can all imagine, when you start talking about sepsis in the hospital, 75%, 80% of these cases actually originate from the emergency department. And so, like it or not, we're going to be part of this collaborative work, even if Medic in the coordinating center isn't necessarily the one that is spearheading it. But HMS certainly recognizes this reality and has reached out to us to talk about how we can coordinate around these efforts. I think we all have a general interest here because there's nothing worse than being measured when you have no stakeholder and no influence on how that measurement occurs. And so an example of how we're thinking about this is partnering on a collaborative meeting in the future, probably in 2023, with a focus on sepsis, where we bring in external speakers, and it would be a joint partnership between our two collaboratives. So literally a meeting with like 300 to 400 people focused on sepsis. HMS is in the process of determining how they're going to do their measurements. They're taking a long view of sepsis. So both the acute care aspects of it, the initial few hours of care that we're very familiar with in the emergency department, as well as the longer term after effects of sepsis as well. And many of these quality measures and measurements, especially in that acute care phase, we're familiar with. I mean, these are things that we're already wrestling with. This is something that CMS is measuring for us through the SEP1 measures. So I think there's a lot of alignment here, and I think everything here will feel familiar, but we'll have, I think, additional pressures on our work for those hospitals in HMS and Medic. And to be honest, HMS, there's something like 80 of these hospitals that are participating in HMS. So there's a lot of overlap here. So more to come about sepsis in the near future. Okay, so now let's talk through some of these population health initiatives. This is on the tobacco use cessation initiative. We've talked about this a few different times. We just heard about it some more from Mike's talk. We've offered this opportunity already, and certainly one of our groups, ECS, is interested in piloting it. And we're in the process of figuring out how we do some of the measurement required for the program. This initiative does provide some VBR uplift. This was mentioned before. It's 2%. So this is on top of all the other VBR programs that we are already involved with. HBOM offers a lot of materials and help in doing the kinds of interventions that we'd be looking to do. The type of counseling that's required is actually pretty minimal as counseling goes, but it has to be provided by a provider in the emergency department, at least the initial conversation. But these are some of the materials that would be free of charge that could be offered to patients that would come from the HBOM collaborative. So they're trying to make it easy as best they can. And so again, if there's any interest out there, aside from those that have already stepped up, please reach out to us and we can start having some conversations about how to make it work for you too. Okay, another one that was brought up earlier too was around health disparities. You know, we've been talking about this for a long time to this point. Our last collaborative meeting, we had Jonah Khaldoun as our outside speaker talking on this topic. I think what we recognized early on was we don't have enough understanding of how the important data fields like demographics are collected from our sites. And in our most recent change for the data dictionary, we're looking to do better at understanding how that data comes to us and how we curate that data to be able to understand how we measure health disparities. MShield is more of a consultative CQI, so they don't have things like a registry or hospital memberships. So they're there to support other CQI's work. And then finally, let's talk about some of the work we've been doing already around opioid use disorder and harm reduction. I'll get into a lot more details here in my transition to the next section. But work that's been going on for 2 years to this point that's been pretty successful. Okay, so let's transition a bit. I'm going to set this up. Here's, I think it's important to understand how we think about the long horizon around quality initiatives. There's quite a lot of planning to consider as you turn on a new quality initiative. There's a life cycle with all of these quality measures where, assuming that we do good and we continue to improve, we may plateau. We may find that we have topped out on our ability to improve and ultimately enter a maintenance phase or a retirement phase. We've done this with the pediatric head injury overuse measure for various reasons. And as a result, we have to continuously be thinking about where else do we want to expand into? What else do we want to turn on? Where are the opportunities for us to do that? And the time is right. And this is going to be our proposal, which I'll get into in a little bit here. We had initially had this conversation, to be honest, a couple years ago. But like all things related to the pandemic, we really had to sideline the work as we dealt with the implications of COVID on our work. An example of this is we had to put into kind of the maintenance parking lot phase temporarily the work around chest x-rays in children and PE in adults. And as a result, we didn't push forward on this. But we think the time's right from the coordinating center perspective to build out a brand new quality initiative. I think it's important to understand some of the rationale for how we in the coordinating center think about what makes for a good quality initiative. I think first and foremost, you need to start with the evidence. Where is the literature? What supports best practices? What do clinical guidelines recommend? Where are the sort of points of authority around what we should be doing? Second is the opportunity. It's great if people are doing well already, but what we want to identify is where we are in a current state and we can move to a more ideal state. So we have to have opportunity to improve. And then finally, we have to have impact. And impact can be measured in a whole host of ways. With a lot of our other quality initiatives, we're focused on reductions in low value care, which certainly come with reductions in spending and costs that may be unnecessary. But there are other ways to consider impact. Certainly, a lot of patient outcomes are important. So reductions in morbidity, reductions in mortality. And I think this next one that we're going to present, I think, focuses more on mortality reductions. So I want to make the case for moving into substance use as a population that's important to our care setting. I think we all recognize that the opioid epidemic broadly impacts communities and healthcare a lot, but I think it's particularly relevant to our care setting. We have oftentimes a moment to make a difference in patients with substance use disorder. And I think it's important that we think about this as a population that we want to invest a quality initiative around. This particular study is really, I think, important to me as I think about the work and the opportunity. It's a pretty simple study. All they did was ask the question of, if a patient comes in after an opioid overdose, what happens to them when they leave? And they looked at mortality. And it's pretty shocking. Within a year, 5% of these patients have died. Within 1 month, 1% of these patients have died. And you think about like all the time and energy and effort that we spend on some of the other conditions and symptoms that we focus on, for example, chest pain and its overlap with acute coronary syndromes and other cardiac conditions. If we had these types of outcomes within 30 days of an ED visit, we would be focusing tremendous amounts of effort on that population. And I think similarly, we should consider this one. Regarding the evidence for naloxone specifically as a harm reduction strategy and intervention in the emergency department setting, I would say the evidence is modest. We don't have, say, randomized controlled trials that clearly link ED naloxone to differences in patient outcomes. But we have reasonable evidence, and here's an example. This is not focused on the emergency department. This is focused on the community setting, but I think there are clear analogies here. This comes from the British Medical Journal. They effectively studied different communities in the state of Massachusetts. They characterized these communities based on their level of implementation of a naloxone harm reduction program into 3 groups. One where there was no implementation, one low, and one high. And then they measured their outcome, the risk of mortality within those communities. And they found this dose response curve. Those that had higher levels of intervention were more successful in reducing deaths from overdose. There are a lot of these kind of studies out there, these kind of observational studies and modeling studies, and this is the evidence that we'd be using to help support our work. There are also quite a number of clinical guidelines and recommendations around introduction of naloxone into the emergency department. Certainly the CDC, SAMHSA, which is the federal agency focused on substance abuse, but also some of our own professional societies. This is a policy statement from ASAP that's recommending that we adopt this practice. More specifically from ASAP are recommendations around which populations should be receiving naloxone depending on their risks. You can see there are a number of groups that could receive naloxone given their risk profile. We're going to focus on that top one, which we've highlighted in orange as a basis for our quality measurement. These are patients at highest risk again, the patients that came in after an overdose. This also aligns with a lot of the pilot work that we've been hinting at through the early part of the morning here, where we've really learned a lot about how to do the interventions, the workflows, and the quality improvement work. Many of these EDs overlap with those that are in medic, some do not. We've been providing these sites with a lot of materials to support the work. Here's a picture of what we supply. This is what we call a kit. So it includes both educational materials that are tailored to the community, some educational sort of instructions for patients about how to use naloxone because they have to learn how to use it. We use the nasal version, which we think is the best, to be honest, for the general person to use rather than the injectable. The naloxone medication itself, we supply as part of the kit, free. We actually use a program that the state of Michigan has where you can get this medication for the state for free, and we help coordinate that process. And we anticipate that this is the kind of support that we'd be able to continue to provide, as we roll this out as a formal quality initiative within MEDIC. When we start talking about quality measurements, it quickly becomes apparent that you need to know a lot of details around how you define numerators, how you define denominators. This is something that we will continue to iterate on, but this is likely to be pretty close to the final version of our quality measure. So let me walk you through this. In the denominator, what we'd be looking to identify are ED visits pertaining to opioid overdose. We'd be using ICD-10 diagnostic codes and chief complaints to make that determination in our registry. We'd probably impose an age limit here. At the moment, it says age 5. We'll be sort of iterating again about that. And then restricting to those patients that were discharged home, because that's the kind of patient population you have control over. When they're admitted to the hospital, it gets a little bit more complicated around the workflows for naloxone, and certainly those that are transferred makes it harder too. So that's the denominator group. And then the numerator group would be those patients that received naloxone, either as what we're describing with this kit. I think we would also credit prescribing naloxone. And certainly there's instances where you may offer naloxone and the patient declines, but we'd want to give you credit for that. And so like all our quality initiatives, we would use the registry to identify these cases, and then rely on the abstractors in their chart review to exclude cases that don't fit this population, and also know things like, was naloxone given or offered. And so at the end of the day, it'd be a percentage. And like all our quality initiatives, we began by measuring baseline performance first. We'd start doing that in 2023. And then we would understand baseline performance. And then just like we do with all of our other quality initiatives, work through our methodology to determine what our targets would be, so that in 2024, we'd be in a position to integrate this into our P4P. I think it's important to recognize that we would need to begin this infrastructure building in the summer and fall. So the coordinating center would be doing a lot of investment in building those modules, testing the questions, and validating that we have the process correct before we turn it on, ultimately in our standard performance year, so like November or January. I know this may be causing some anxiety to a lot of abstractors out there, but we'd be working with you on how we structure these questions, and I anticipate that it'd be similar to the pulmonary embolism module in length. So that kind of set of questions rather than something like head injury. We've done some scoping within our registry to understand how many cases are we really talking about here. And so this is a table that shows those numbers going back several years into the registry. Probably the 2021 column is the most important here. Just recognize that some of these numbers may not be a full year's worth of data, but many of those sites have been in 2021 long enough that it probably represents the total cases. We'd be relying actually on an already validated set of definitions for identifying cases of overdose from the CDC. So they've already done a lot of work in their efforts to do surveillance around these events, again, leveraging those diagnostic codes and chief complaints to identify those cases for the denominator. I think one thing I'd point out here is the cases are actually small volume relative to many of the other initiatives that we're involved in, which I think is a good thing, especially given all the pressures on the abstractors and their workload. Remember too, that we'd be incorporating these case counts into our new FTE model that we'd be rolling out over the summer. So obviously, if there are additional cases that would bump up FTE allotments to our sites, that would be part of this process. So we'd be matching the effort required here with the funding to support it. I think a couple other take homes when I look at this chart is that there are obviously a couple pediatric only centers here, and those volumes are pretty small, when you look at the numbers. And so this is probably not at the end of the day going to be a measure that includes the pediatric centers if it's at the site level. However, it could also be that we choose to do this more at the collaborative-wide measure level, which we've done in the past. And those kind of decisions we would go through in our standard process with the executive committee, as we make those decisions together. Okay, that's all I got. That was a lot. Let me pause and see if there are any questions. And actually, one thing I want to say, which I actually didn't say, was we actually vetted through this quality initiative with the executive committee in the last month. So we presented the same information to the executive committee a few weeks ago, had a conversation around this where, we had a free exchange of questions and ideas, and ultimately voted on this as this proposition as a new quality initiative. So we worked through that process and got approval by the executive committee, as we standardly want to do. So we're approved to go forward with the quality initiative. Okay, that was an important point. I'm glad I remembered it. Okay, any questions that might have come up?
Nope, we've got a quiet group today.
I'm hearing no questions, people. Well, this is really important. We want to be sure that we hear from you, given the implications of our work and our strategic next steps in Medic. So please reach out as questions come along to us, so we make sure that we address any concerns.
We do have one. Sorry, they're coming in now.
And we have one question.
Yep. So wondering how the FTEs would be figured out for the opioid initiative for new hospitals, especially given some hospitals, we only have some of their data to this point.
Yeah. So what I'm hearing is how Medic generally approaches assigning FTEs for new sites. And we do this all the time. In fact, it's not specific to, say, the opioid initiative that we're proposing. When we don't have data, we have to rely on your own internal data at a hospital. And we give you all the codes and the necessary definitions for you to get into your own data warehouse to give us the numbers. And that's what we rely on to then match with the FTE assignment. And then we adjust that, when we get into the actual registry and we have more data to support a better understanding, we make that adjustment the next time that we're able to. That can only occur on an annual basis, though. Now, if we have enough data in a registry for a few months that we can confidently feel like we have an understanding here, then we can use our own registry data to match that up with a new hospital. But that's usually not the case as we're onboarding new sites.
One additional question.
Yeah.
Wondering whether this measure would replace an existing measure.
Yeah, really important question. I don't have an answer. I think this is why we have a governance structure, why we have an executive committee working in partnership with the coordinating center. There are, I think, a variety of reasons where we want to position new work and not stretch out too far old work. And so it's very possible that we eventually retire one of our other measures. But we want to be in a position to have another quality initiative in action to balance out new work with old work. So as I mentioned, there's a long life cycle to quality measurement, and it's something that we'll decide together in the future.